Hey everybody, Dr. Rob here. I'm here with a luminary in the areas of functional neurology, functional medicine, one of the smartest guys in the room without question. I'm excited to have him here, and he's going to share some ultimate knowledge bombs. Dr. Datis Kharrazian. Doc, how are you today?
Hey, Rob. Hi. Pleasure to be here. Nice. Thank you.
This is exciting, man. I've been following you since I got out of school. We got out about the same time, and you've just blazed a great path. So much information. I mean, you're a researcher, scientist, practitioner, author, and a teacher. I mean, your plate's busy, my friend. So let's delve right in. One of the things you talk about a lot is autoimmunity. And in autoimmunity is, I think, let's lay the groundwork. Why is autoimmunity on the rise, and what is autoimmunity?
So autoimmunity is just when the immune system starts to target some of the proteins or tissues in your own body as being foreign, like a pathogen, and starts to create an immune response against it. And the key feature of it from a laboratory diagnostic point of view, what we call autoantibodies. So antibodies are typically made, as most people know, to fight a pathogen. So if you get a virus in, your body makes an antibody for the pathogen so the immune system can find it and destroy it. So autoimmunity is where the immune system basically dysfunctions and starts to make antibodies to the body's own tissues. It could be an enzyme in the body, it could be a protein, and a sort of various tissue in the body. But then the person starts to have their immune system destroy their own tissue. And this really then creates a chronic degenerative cascade. And unfortunately, no one has really figured out the cure for autoimmunity. It's really just a disease where you can put it into remission and slow down the expression response of it. At times, sometimes people may feel like they're cured, but they do have ups and downs. They do have flare-ups, and it's really a growing disease. No one really knows why autoimmune disease has been exploding. The rates have gone up. It's also starting to affect a younger population than ever before. I mean, the scientific theories are basically that there's an environmental component, where there's different chemical exposures over a period of time, different genes that are susceptible, changes in how we change proteins in our food through hybridization, through GMOs. So it's basically this like soup of, chemicals, pathogens, genes, environmental exposures that all start to merge together that then changes the expression of the immune system. And once this switch turns on to attack the body's own tissues, it's really difficult to turn it off.
Fascinating. There's a lot to unbox with that. So it's the body's producing antibodies. So it's the inability of the immune system, if you will, to differentiate between self and foreign,
Yep.
producing an autoantibody. Now, do those antibodies attack each other?
There's some complex proteins like agglutination where some antibodies can react with each other, but for the most part, what's more fascinating, I think, with that is that what they're finding is antibodies made to one tissue can actually bind into another. So, for example, the most common autoimmune disease in the world is Hashimoto's, which is the main cause for people to become hypothyroid. So, 98% of the people that are hypothyroid actually have an autoimmune disease, whether they know it or not. But what they recently found in the past 10 years is like these thyroid antibodies, TPO antibodies, can also directly attach to proteins in the brain, uh, specifically the cerebellum. So then these people are actually getting degenerative changes happening much faster in the brain, and they get this neuroinflammatory response in the brain, and they may not be aware of that. And this is really why many people have like Hashimoto's, or they may know it as just being hypothyroid. Even though they're on thyroid replacement, they're not really getting anything done to manage their autoimmunity, and they continue to progress. And this is why doctors usually have them come in every year to get their thyroid levels checked because they expect their thyroid tissue to be destroyed more in the next year or so. So they may need to increase their dosage. But for example, this connection between these antibodies binding to other tissues like the brain is just totally ignored. And then they may have these degenerative changes taking place in the brain and specifically the cerebellum that'll impact people's cognition, their balance, their ability to handle motion and movement. So this is, I think, what's really fascinating about antibodies and autoimmunity is that we're learning that they're not just attaching that one tissue that we first thought, they're actually attaching to multiple different tissues in the body. And this is a very interesting area of exploration as a clinician and as a patient dealing with an autoimmune disease.
So these antibodies that are getting attacked, obviously there must be a stimuli. So I'll throw one of the stimuli out there. Probably one of the biggest egregious ones would be gluten. Am I correct?
Yeah, the thing with autoimmune disease, this thing that's very frustrating for practitioner and the patient, it's, in the classification of a multivariate disease that isn't one variable. So there's some strong associations, for example, with celiac disease and many autoimmune diseases and gluten reactivity with many different autoimmune diseases. but it's not like one thing. Now, there are some strong variables that have a greater power and effect on a tissue. So that, for example, if someone has severe reactions to gluten and they have celiac disease, which is an autoimmune reaction to gluten, they have genetic overactivity of how their immune system and their T cells respond that are much more aggressive even than how they react to a pathogen. Some of those celiac diseases, for example, turn on, like we talked about, celiac, like Hashimoto's hypothyroidism very aggressively, in which even when they've done some studies where they have people come off gluten, it can pretty much in some cases reverse the condition, put them into remission immediately, but in others it doesn't do that. So, the frustrating thing is if you have autoimmune disease, like you go on the internet, you just read those simple things like if you just fix your microbiome, it's going to go away. If you fix leaky gut, it's going to go away. If you're just gluten-free, it's going to go away. And those things may have some impact, but I think the key thing to understand about some of these chronic diseases, especially autoimmunity, that it's a multivariate disease, and these variables that can trigger and push the disease can change over time. And they can change as your genes change. So, for example, as you age, certain genes turn on, certain genes turn off. So the disease is always dynamic and it's always changing. And there's just this constant battle of trying to figure out the right diet, nutrition, lifestyle, nutraceutical intervention to try to optimize function. But it's not linear. It's not simple. It's not like, people use the word root cause. It's not a root cause based disease. There's multi variables, and people are like searching for like this one root cause that may cause it. But it's much more complicated than that. Now, gluten certainly plays a huge role in many autoimmune diseases because it's such what they call modern wheat in the immunology world, where wheat has been changed in the structure of the proteins and the protein sequences through things like hybridization of seeds, through things like what they call haptenation, where chemicals like glyphosates bind to gluten and change the protein structures to become much more immune reactive. With certain gene pools, it becomes devastating. So these are things that are all happening. So it's a bit complicated, And I think the average person that's suffering is just trying to look for a simple answer, or simple thing, and it's not always so simple. And I only say that because there's definitely hope that you can do things to dramatically change it, but it's a dynamic game. It's not a simple rule. It's not like one root cause for all these things when you're dealing with a multivariate disease like autoimmunity.
You just really explained something truly complex, and the basic premise is that this root cause resolution is a great concept, a starting concept, but it's really root causes
Right.
resolution. And I've got something that you said, that autoimmunity, there's no magic pills, just lifestyle changes. And
Yeah.
you indicated sleep, stress, exercise as a few. Could you give some of the remedies to autoimmunity? I know you won't be able to give everything because you take everybody as an individual, n equals one.
Right. So, the thing is there's some, the key feature of autoimmunity when you look at it and kind of dissect it down to what's happening with the immune system, there's some key features. And in the world of immunology, they refer to it as loss of tolerance. So that it's a field of immunology where the immune system has a hard time distinguishing their own tissue from foreign tissue, and that's the whole hallmark of autoimmunity. And when people lose this tolerance, what they found is that there's many different immune players that are involved. So there's a very important cell called regulatory T cells. They regulate how aggressive the immune system responds against something. They are dysfunctional. There are cells called dendritic cells. These tend to be overactive with autoimmunity. There's even cells in the liver, like Kupffer cells, that are like the immune cells of the liver. They become overreactive, overzealous. There's changes in how different antibodies start to react against the cell tissue proteins. There's messages in the thymus gland that can dysfunction. There's all these different areas, but there's this loss of immune tolerance. There are some general rules that seem to have some effect on loss of immune tolerance in all aspects of immunity. For example, sleep. I mean, it doesn't really matter if you have a chronic infection or autoimmune disease. If sleep is necessary to really help prime the immune system, help it function well. Lots of different physiological steps take place to balance out these systems. So sleep is a big issue. There's a phenomenal explosion of research on exercise where they're finding muscle tissue itself releases proteins called myokines, and there's also things called exokines that are released when we move that then modulate the immune system, different T cells and B cells, and some of these immune players and these chronic diseases that seem to have a very powerful effect. Um, and there's just a whole entire explosion of research the past 10 years on the psychoneuroimmune response, where how we deal with stress really impacts how these immune systems express. So the very basic fundamental things for someone who's got a chronic disease that involves the immune system, like autoimmunity, is, the three key ones are like sleep, exercise, healthy relationships. Those things make a profound impact. And it's almost like if you're dealing with a immune-mediated disease or a chronic disease, you can't go wrong starting with those.
Those are great lifestyle hacks. But you brought
Yeah.
up the idea of immune tolerance.
Yeah.
Some of the things in our field now, people are talking about immune competence. So could you differentiate between competence, excuse me, and immune tolerance?
So immune competence is like in the field where you're trying to see, can your immune system actually fight and destroy a pathogen? Can it actually do its job? And immune tolerance is, does the immune system know how to distinguish? So the key feature is this ability to distinguish between self tissue and non-self tissue, like pathogens, for example. And tolerance is its own field. And what we're finding is tolerance is being disrupted much earlier than ever before. We're finding like many mothers who have children, their offspring tend to have autoimmune disease much earlier. There's a bunch of research that's really shown things like autism may really be autoimmune disease while the baby's developing. And there's these studies that have clearly shown like kids that are born that end up developing autistic traits later have brain autoantibodies developed from the minute they're born. They can see these immune responses taking place. So tolerance is really about distinction of self versus non-self. And competence is about how effective the immune system is destroying tissue or a pathogen, I should say.
So give me your three best things for people listening to try and quell some autoimmune. I know I don't want to wrap you in a box. I'm going to
No,
give
no,
you
no.
latitude.
There's some generalizations you can, so with like autoimmune chronic diseases, there's some generalizations you can make, right? And just for general health, like people definitely need to figure out their sleep. Sleep is a big one, right? Now, there's some people that have a chronic disease or autoimmunity where sleep will be a key factor. It'll be a huge variable for them. Like they will know for example, if they don't get good sleep, they're gonna have a flare up. Let's say someone has rheumatoid arthritis. Rheumatoid arthritis is one of the most common autoimmune diseases as well, and that's where people have like the swelling of their joints. They start to get arthritic changes. Their joints start to deform. They may notice like the arthritis really flares up if they haven't had a couple nights of sleep that are good. They notice when they start sleeping better, their inflammation and joints a lot better. So sleep is a big one. So sleep will involve like, can you fall asleep? Can you stay asleep? Um, How's your sleep quality throughout the night? Are you waking up several times throughout the night? Like you could have someone who has autoimmunity and they have sleep issues, but the sleep issues maybe they have an overactive bladder. So they keep waking up every few hours. So they never get this long extended sleep, which is what the immune system needs. So, as a clinician, maybe we're working with how do we try to support the overactive bladder? Maybe we have to have them stop drinking any kind of fluids by 6 o'clock, and then they can start sleeping through the night. It all depends. For other people, they can't sleep well and they tend to like get hypoglycemic. They wake up in the middle of the night, 3 or 4 o'clock, with the heart rate up, they crave sugar, they eat something, go back to sleep. So even though like sleep is an issue in a clinical setting, you still have to figure out like what's the variable with sleep? Are they not getting extended periods of sleep? Could they not stay asleep? Some people just can't fall asleep. That's another issue. So, even though we say like, oh, you got to sleep better, and a lot of times in a real clinical setting, we then have to figure out what are the variables that are causing their sleep to not be efficient as well, right? And sometimes it's just like poor sleep hygiene. They're just staring at their phone all night, or they're just distracted. They're not going through a ritual to help their body relax and calm down so they can sleep. And some people have to figure that out. Like for some people, they have to like exercise really hard that morning to sleep that well that night. Other people have to like if they exercise too late in the day, then they can't sleep. They're too wired. Like there's just definitely trial and error. And this is
Good
what's
stuff. So,
yeah, and this is what's so frustrating when you like I can't watch social media stuff with healthcare practitioners anymore. I always watch and I just go, you've never clinically practiced. Like it gets so frustrating because people just try to put these general rules on things, and it doesn't really apply that way. Everyone that has a chronic disease has to go through a period of trial and error with key concepts and then figure out how they apply to them and what's working for them. So, for example, someone has a debilitating autoimmune disease, and someone goes, oh, if you want to sleep well, you just need to have your room temperature be 75 degrees and you have to have this perfect mattress. And they may do that and has no effect with them. Maybe it's the person that has to eat, six high protein meals throughout the day so their blood sugar doesn't drop at night. Then maybe that's their answer for being able to sleep through the night. So we can get with some general principles like sleep, but ultimately it's like how good is the quality of your sleep, and then what are some of the variables that are affecting it, and that's where you play this clinical game. And for the person who's dealing with a chronic illness, it's really frustrating because all you see out in the world is these generalizations without really individuality. And it's even more frustrating when you go see a practitioner and the practitioner doesn't dig deeper and they don't know how to clinically dig deeper. And then they're frustrated, like hoping they would have the answers and they don't. And then, this is why we have this growing population of chronic disease that just feel abandoned and have nowhere to go.
You make a great point. This is the first podcast you said you've done in 3 or 4 years. I'm going
Yeah.
to be using Reels. We're going to be on Instagram and all that. We're going to be sharing information. And there are some influencers like you. I found they're abhorrent. That said, let's talk about what we do, the concept of functional medicine, and let's talk about some of the things that are wrong that need to be corrected to right that ship.
Well, I mean, functional medicine, I mean, I'm a functional medicine practitioner. I identify myself as the functional medicine educator, and that's what I do as part of my career. And the principles of functional medicine are wonderful because the goal is
Right.
to try to improve function. And function could be making sure hormones are optimized, making sure your blood sugar is stabilized, making sure your immune system is competence, making sure your immune system is tolerance. You're just trying to improve function. And when you look at, for example, conventional medicine, pharmacology is completely opposite. It's everything is there to block and inhibit, right? So we have protein pump inhibitors and beta blockers. It's all block, inhibit, downregulate, serotonin reuptake inhibitors. If you look at the top common drugs, they're all blocking, inhibiting, downregulating, and that's not really increasing function. That's shutting down a part of physiological function for some kind of clinical outcome or a biomarker outcome. But the goal of functional medicine is, are your physiological functions all operating at their peak, right? Can you have normal bowel movements throughout the day? Is your energy level stable throughout the day? Is your cognitive function stable? Can you have synapses? All these things are the goal of functional medicine. So the principle of functional medicine is fantastic. I mean,
Right.
it really is such a great way to think of how the body works. It's not really disease focused. You're not necessarily coming in and saying, well, for example, we talk about autoimmunity. So as autoimmunity, you don't just go to like an autoimmune protocol, autoimmune drug. You go, what part of their if they have autoimmunity, what are the variables? And we talked about sleep, for example. So then you have sleep, and then they go to the variables that may impact their sleep from a functional medicine point of view. Like we talked about examples like overactive bladder or blood sugar dysregulation. Maybe they have high cortisol or something like that that's impacting their levels. But the goal of functional medicine by itself is a phenomenal concept. Except one of the problems we have with it is like people that practice functional medicine may not really understand it that well, or they don't know. They don't. Functional medicine is all about depth. How deep can you go?
Right.
And how well can you see these interconnections with the person? And what do you do to improve physiological function? And that's hard. So to give everyone a break that's practicing functional medicine, it's not an easy task. And since it's not an easy task, people sometimes try to simplify the steps involved, and that's where you get, sometimes very simple equations. Like I think what's failed with functional medicine education is when people say stuff like educators say stuff like, well, if you don't know where to start, just start with the gut. That just basically means you have no idea what you're doing. And by the way, everything a person does is going to impact the gut. If you sleep, that's going to impact the microbiome. If you take hormones, that's going to impact the microbiome. If you exercise and move, that's going to impact the microbiome. So, but what they really mean is let's start with the gut with supplements. And so, one of the things that's kind of, I think, translating to functional medicine that's become made it a little more inefficient for both the patient going through treatment and the practitioner providing it is it just becomes the which supplements do we start with? It's really become the supplement game, and it's really become like how many labs do you order? And this partly, I think, influenced by the main educators of functional medicine have always been nutraceutical companies and laboratory companies. So they have that heavy, heavy influence on
Right.
the model of functional medicine. Because when you go to a conference, when you go to a seminar, they're usually held by some of these companies, or if you go to the vendors at a conference, they're all there and they all have their influence on the speakers, and that really starts to kind of strongly influence it. So, you can almost tell when someone's gone to a functional medicine practitioner that doesn't know what they're doing because they'll have hundreds and hundreds of tests and then hundreds of supplements and like very little focus on the actual lifestyle or interactions and how these things work and prioritizing. And for myself as a functional medicine educator, um, one of the things that we talk about is like it's not easy to find every things that are wrong. Like if you take an average person and run different panels. Let's say you run a GI panel, you're going to find some type of microbiome imbalance or some type of digestive marker that's a little bit off. If you run like a red blood cell nutrient analysis, you can find some nutrients that may be low in another in some person or another. If you do run some kind of toxicology profile, you'll find certain environmental chemicals are off. So if you run enough, when you run a bunch of these tests, you're going to find people will have little imbalances or even sometimes big imbalances here and there. So finding them is not the hard part. Prioritizing where to start and how they all interact with it is really the skill of functional medicine.
Great point.
So I think what happens to a lot of people who learn functional medicine or work with a practitioner in functional medicine, they just kind of do this deep, search for everything, find everything, and then try to supplement everything. And this is where patients get frustrated because now they're spending thousands and thousands of dollars on tests that they may that doesn't really help start in the right place, and then taking all these different supplements that because they're treating every lab marker that's abnormal with the supplement, just like people treat every drug with the every disease with a drug and end up with multiple drugs. And this is, I think, where things can go wrong quickly in a functional medicine approach.
I wholeheartedly agree with you. I wrote a question down. In your opinion, I mean, you own an institute.
Yeah.
It's all about learning. It's all about helping the patient via information.
Yeah.
What's missing in most practitioner education, especially with the rise of this protocol-driven care? Everybody says, "Hey, Rob, what's a protocol for autoimmunity? Hey, Rob, what's a protocol for rotator cuff, etc."
Yeah, so that's I think that's one of the problems we have. It's like in a functional medicine approach, we're not really protocol by disease-based conditions, right? Like we may have protocols, for example, what are some protocols if we see white blood cells low? Look, there's some things we know with lifestyle nutraceuticals that may have an impact on raising white blood cells, but it's not for a certain condition, right? What are some of the protocols and lifestyle factors can improve insulin signaling, right? But it's not necessarily for a certain condition, but you're just trying to, let's say, improve insulin sensitization. So like in a functional medicine model, it's not really the disease or condition that's approached. It's really what's the mechanism of the physiology you're trying to change with them, right? Are you trying to activate GABA receptors? What are you trying to do? So that's where we have some interventions, and we have to have some degree of things we know we do for certain mechanisms, but it's not really disease or condition based. So I think that's kind of the shift in learning. So I have my own institute, the Kharrazian Institute. We have over 5,000 doctors, healthcare practitioners that have been studying there since 2016. And recently, I made a new educational program called the Academy of Functional Nutrition and Lifestyle Medicine. And this was because we noticed that a lot of our functional medicine doctors and especially physicians just didn't have any real training in nutrition protocols. And like a dead giveaway practitioner doesn't really understand like the foundations of basic nutrition, which is one of the key essential parts of functional medicine. Is they just basically use a supplement that a nutrition company recommends that they like, and that's kind of how they think of things. They think of like, oh, I have this GI product from this company for this, and I have this, but they don't really know which of the ingredients or how they use them, that or distinguish one supplement to another. So it became, for me as an educator, it became very clear, like, okay, our a group of practitioners, especially physicians and nurse practitioners that never really got any good training in nutrition. Also, many chiropractors, acupuncturists, they never really get really foundational good information in nutrition. They were having a hard time getting to the next level because they never had that background. Even for myself, when I was on my journey, I'm like, I need to learn more. I had to get a master's degree in nutrition, do a lot of self-study, take a bunch of conferences and courses to learn how to apply it into a clinical setting. I mean, it's a skill you have to have. So I think a lot of practitioners that learn functional medicine, they never really had that strong foundational background in nutrition. Like they may not know the difference between evening primrosole and borage and EPA and DHEA and what kind of compounds are in them, how they have a different effect clinically. And they just think, oh, well, I'll just take, I like fish oils, I'll just use this.
Right.
And you can't use flaxseed oil, that's acetal oil, that's going to cause harm. And they kind of misinterpret what they mean by cooking oils and rancid oils versus supplemental, and that whole foundation is just gone. And they think, oh, well, if I just give multi, it'll cover everything, so that's good. And that's not really how it works. So as an educator, I'm seeing like this mnemonic, like starting with the gut, or just do what's called, like, for example, like a 4R program or 5R program, where they say like replace, reinoculate, restore, like these basic rules. Just simplify things too much where they don't have the strong foundational stuff. So for myself as an educator, when I developed the Kharrazian Institute and created the functional medicine program, it's a 300-hour program. We have 200 hours of coursework, all with the evidence-based research and mechanisms of physiology that aren't really focused on protocols for conditions, but protocols and physiological mechanisms. Then I have 100 hours of clinical ground rounds where you see me actually work with patients in my practice, really, monitoring some of the patients we followed for 2 years, like the first intake to how they follow up with labs and things over time. So they get real clinical education. And then recently I'm like, okay, we're having a hard time in our group, and this is where started the Academy of Functional Nutrition Lifestyle Medicine because they're like, we got to give them the foundations, fundamentals of clinical nutrition, not academic nutrition. So it's like this evolving step. And then when you really get into, then for me, I realized ground rounds, clinical ground rounds were a big issue because people learn about functional medicine, but when you actually work with a patient, it's never anything like you learn in a seminar. There's multiple variables you're trying to pull on at the same time and see how they interconnect. And I mean, the other thing, to be fair, it's a long journey. Like for people that want to learn functional
Right.
medicine to well. Not to say you can't get clinical results not being very good at it. You can get dramatic clinical results with people in the health, dealing with health chronic conditions today just by simple concepts of functional medicine. But as you're dealing with chronic disease like autoimmunity, you really have to have this, this level of depth to be able to figure things out and go through the trial and error journey with your patients to see what they respond to and figure out what interventions are really working best for them. There really is a need for this individualized personal development with each individual person.
N equals one. I agree. I've heard you circle the wagon a little bit with gut. So let me
Yeah,
ask you something about the gut to brain immune axis. You're
sure.
an expert on it. We now understand about the gut to brain connection. That what is it that we now understand about it that we didn't know 5 years ago?
There's a lot. I mean, I wouldn't call myself an expert. I consider myself just being exposed to it as some of the research is coming out as well. But we know like the gut itself, the microbiome it releases what are called postbiotics. Everyone knows the word prebiotic, where we like things like fiber become help support beneficial bacteria. And then and as we stick to the microbiome for a second, the microbiome is also more complicated than we ever thought because what we used to call bad strains or good strains, it's not that simple.
Mhm.
And what we're finding is even when you talk to the top researchers studying the microbiome, they're like, we can't label these things, and it's so complex. We're going to have to use machine learning to even have a clue of what different bacterial profiles that work and integrate together are actually having a effect. They're having effects in different ways. But ultimately, it's about these bacteria in the gut, and these bacteria in the gut release what I call postbiotics, which are like signaling molecules, things like lipopolysaccharides. Some of these bacteria produced different peptides and neurotransmitter substances. And these are communicating agents. So the bacteria we have actually create these messenger systems throughout our body. And these messenger systems can impact our brain, since we're talking about the gut-brain axis. But these messenger systems can get into our blood, into our circulation, then cross the blood-brain barrier, have an effect. But we also have direct pathways that go from the gut itself to the brain. Uh, like the vagus nerve innervates the entire gut, but goes right up to the brainstem. So some of these messenger pathways go straight up to the brain through these what are called canalized pathways. And then the non-canalized pathways are basically what's, the neurochemical environment that we have in our system, in our body. But the microbiome is definitely having an impact all throughout the body, as we've always known, in the fields of natural medicine, but now it's great to see all these researchers doing it. So there's an explosion of like the microbiome diabetes connection, the microbiome islet cell, the microbiome pulmonary connection. Like
Yeah.
everything access is now there's like a gut something access, right? Gut pulmonary access, gut renal access, gut liver access, gut everything access, because they're realizing that these bacteria in the gut are really having all these influences. But it's not as simple as like just taking a good probiotic, which then this is where everything goes wrong. They
Right.
just translate it to, oh, you just need to have an impact gut. Like for example, some of the most profound research on what changes the microbiome more than any supplement is physical activity. Like
Mm.
if you look at the research of what happens when people contract muscles regularly, the profound impact of these muscle proteins called myokines and
Right.
extrakines, these bacterial species, is much, 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 much more profound than ever taking like a supplement. So, like as a functional medicine educator, we'll see stuff like, yeah, I got my patient, I put them on all these supplements, I hadn't changed their diet, they're eating all these foods, not fermented foods, they've restricted all gluten, dairy, soy, all this bad stuff out of their diet, they're not eating any sugar, and I still can't change their GI panel. And like, tell me more about the patient. They're like, well, they're so tired, they're sedentary. I'm like, why don't you just start there? Why don't you just have them go for a walk? Why don't you have them start moving, pushing that a little bit? Because that's going to have a very profound impact on the microbiome. So, and then, there's also studies that show like if someone's in a hypothyroid state, their microbiome is completely like dysfunctional. So sometimes like fixing in the functional medicine, a lot of times you find out is like fixing the gut really involves going in other areas. And the mistake is just to focus on like supplementation for it itself. And I think that's one of the frustrating things. So going back to your original answer, like the gut-brain axis, there's all these relationships between the microbiome and gut. Diet and lifestyle factor has an influence on it, but these other variables may have a profound impact. And for clinicians that are actually measuring like gut through different biomarkers like a microbiome profile or different digestive markers of the panel or inflammatory markers in the gut. The most common thing you see with people that are going through that journey with their patients as they're learning functional medicine is it's not as simple as supplementation. It really has to be this whole patient approach. And you could have a person who's sedentary and the microbiome is terrible, and then you have a move and still nothing changes. And like as a clinician, you go, well, that wasn't the variable that we needed. And then you might find out like they really have to get sleep. As soon as they start sleeping, the microbiome changes. And the frustrating thing is we don't know what's going to change the variable. So as a journey of someone who's dealing with chronic disease, or if you're a practitioner working with chronic disease, you have to realize it's all about this continued dive into trial and error with the same, like the great thing about labs is you use them as a baseline and they compare them to have some objective information that's happening with them. If you can do that, then you can play this chronic disease game and this N of one game, right? This individuality, personalized approach game.
Let's talk about neurodegenerative disease, autoimmunity, and the gut to brain axis. Is it
Okay.
the gut to the brain? Is it the brain to the gut? We do know that it's bidirectional.
It is bidirectional. So let's talk about the brain to gut axis. There's a very profound relationship between brain function and gut axis. So the brain basically has a very powerful effect on the gut through the vagus nerve, and the vagus nerve is part of the brain stem. But these areas of the brain stem, these autonomic regions of the brain stem, are constantly getting activation throughout the rest of the brain. So you have these different cortexes, different regions of the brain, but they kind of descend down and they fire into an area of the brain called the pontomedullary area, and these pontomedullary areas are our respiratory autonomic centers, and then from there we get activation into the gut. So when they look at injuries with traumatic brain injuries, they see within hours in animal studies complete inflammation in the gut, hyperactivation of immune cells in the gut, severe inflammation. They see leaky gut happen within 6 to 8 hours. So we know like when there's the most acute severe disruption of this axis through traumatic brain injury, that we see these dysfunctions in the gut. There's some researchers that looked at traumatic brain injury studies in animals where they induced traumatic brain injury, but then did vagal stimulation,
Any minutes.
and then all these impacts in the gut were mitigated. They really didn't develop the severe leaky gut. Their immune system in the gut didn't really flare up in acute. So it really showed how powerful this relationship is between brain function and the gut. And the key thing with the brain too, this brain gut axis, is as the brain degenerates, these areas in the nerve called the enteric nervous system there in the gut, they start to degenerate too. So the keeping a healthy brain really means keeping healthy neurons. And when you keep healthy neurons, you're keeping that brain gut axis viable. So as people start to develop neurodegenerative changes in the brain, what they're also finding is the gut is aging, is degenerating as well. When I mean by the gut, I mean the nervous system pathways in the gut from the vagus. So you have these disruptions as well. So when you look at things like neurodegenerative diseases like Alzheimer's and Parkinson's, you see really poor gut function. It's just a consequence of this brain gut axis. You see kids that have developmental delays. You see kids suffering from things like autism. They have really bad guts, and then but a large part of that is this component of just brain health is not there to constantly activate these vagal projections down into the gut.
You're preaching to the choir. I love it. Vagus nerve, cranial nerve, number 10, medulla oblongata down through the transverse colon. The gut to brain axis. Whatever you do to gut, you do to your brain. Whatever you do to your brain, you do to your gut in a millisecond. You may have heard that one before because I think I may have copied it from you. Interestingly enough. So let's turn the page a little bit. I want to know your thoughts on GLP-1, gut peptides, and microbiome-directed therapies and their effect, not on weight loss, but on cognitive health.
Think for me, it's just an area I'm still learning about and looking at cautiously. I think more and more connections are going to come out over time. I mean, you're dealing with a peptide, you're dealing with a signaling agent. When you start dealing with a signaling agent over time, you're going to change receptor site responsiveness and sensitivity to it. I mean, there's definitely a role for peptide therapy in all forms for different types of things. For sure, I've seen people that have severe things like polycystic ovarian syndrome, where they get really stuck in this insulin cortisol web, where they can't get out of it no matter how they diet and do really well with things like a peptide type of therapy. Then you see like the abuse of it. I think we're going to see this, post GLP-1 syndrome coming out over a period of time. I think it's a little too early that, just like all things, when people overdo it, they have some side effects. So I think more information is going to come out with it. But these peptides like GLP-1, they have effects all throughout the body. They're not just affecting the appetite centers. I'm not well versed in the cognitive effects or neurological effects of them, but there's no doubt they would have some effect on them. You probably know more about that than I do.
So without question, whatever we do that positively affect the gut affects the brain. But it's interesting. with these GLP-1 receptor in the dorsal medial hypothalamus communicates with the GLP-1 in the gut. What's interesting is that is a direct communication, the blood-brain barrier is not protecting it. So to speaking to you now, that's exciting for me because that really exemplifies the idea of the gut-to-brain axis, how critical it is to communicate in a proper manner.
Right. Yeah, I mean that's the key thing. But some things that really release GLP-1 naturally, just things like fiber, can have a huge impact on those things. And a lot of times,
Berberine.
berberine, when people, are trying to control their appetite, sometimes just having like a fibrous drink in the morning can have a huge impact on that. A lot of times we'll have some of our patients just take a fiber capsule with each meal. That also slows down the glycemic index response and helps increase and control their appetite centers. And I don't know, there's a place for it. I don't know what's going to happen with because weight loss is such an emotional issue for so many people that it's beyond thinking through what the long-term effects are. So I think you're going to see a lot of overuse and a lot of abuse with it. But I think we're gonna see over time. But there's definitely a place and benefit for many people with it.
The NIH has said 80% of bacterial infections in the gut have had a biofilm, which I call an
Yeah.
acorn to keep it simplistic for my patients.
Yeah.
An example is it's kind of sticky, gummy, kind of like plaque. Now I come to you and I have biofilm. One, what would the test be for the biofilm? And where would you start as a practitioner? Because I know you see patients.
Yeah, I mean, I think with biofilms itself, I'm not aware of any really good laboratory tests to determine biofilm. I mean, if it's like an upper sinus infection, it's pretty obvious. You have the coating in certain areas. You can physically see biofilm when they look at certain endoscopic things, and if they do sampling of tissue, they can see biofilm cells all over the place. But ultimately, the key thing is there's a bunch of like natural biofilm disruptors. There's even mechanical disruption of some of these biofilms people use. But it is the biggest issue I think we have. I think it's one of the things that's going to drive chronic infections. Right now, we just have a limited few of natural compounds that have some strong antibiofilm capabilities, but it's going to be a big factor in different types of pathogen resistance. I hope we develop some breakthroughs with it over time. Um, but it's really an issue. And I've definitely been stuck with some really chronic sick patients not being able to disrupt the biofilm and just like frustrated as well.
It is the bane of my existence as well. Food sensitivities. I believe they're one of the leading causes for chronic hidden inflammation. Also, you can make the case that they're a reason for autoimmunity. What are you looking for in a food sensitivity test that makes you most comfortable?
Well, I think with food sensitivity, we have to understand a couple things about them from a like immunological perspective. There's this one, food sensitivities can have different effects on different people based on multi-variables. This is like this with everything. So there's a very important concept in immunology called molecular mimicry or cross-reactivity. This is where, for some people, a food protein they make, those antibodies against that food protein may then attach to their own tissue. So a really great example of that is gluten, and especially in the celiac disease genetic populations, because they have such an overreactive response to making gluten antibodies and get exposed to gluten. But for some population of people, we don't know what the variables are that make them susceptible. When people make, for example, have an immune reaction to gluten, the gluten molecule can then attach to the myelin sheath of nerves. So
Mm.
now this gluten compound is attaching to the myelin sheath and it's telling the immune system this is foreign. So this causes severe destruction, right? So you could have one person for a set of genes and different variables that have turned on this sensitivity. They have a bowl of pasta and their brain gets severely inflamed from it. Another person may have some gluten antibodies made, but it doesn't have this cross-reactivity reaction with these myelin sheath cells, so it's not as devastating for them. So certain food proteins can have molecular mimicry for different target proteins in the body. And for example, some people are very sensitive to milk. Milk proteins, like casein antibodies or milk butyrophilin antibodies, they can attach to certain tissues in the body for some populations. We did a large study where we looked at all the different thyroid target sites like TSH, T4, T3, reverse T3, 5-deiodinase, all the whole thyroid axis, and we checked 208 foods against them for molecular mimicry. And we found the study, we published in the Journal of Thyroid Research. And we try to signal like if someone has hypothyroidism or is not making T3 well, these are some of the food studies that may be more relevant because they have this potential for cross-reactivity. And what you do in a lab is you take a monoclonal antibody in a lab and then get the target protein and then measure the degree of reactivity using what's called with optical density measurements, and then you can map this cross-reactivity molecular and make a list. We did a study like that too for diabetes, and I remember what the title of the paper was, but we looked at 200 foods that cross-react with islet cell proteins, and we found that many of the foods that cross-react with islet cell proteins were low glycemic foods. So we're saying in type 1 diabetes, autoimmune diabetes is low glycemic index really the key thing. Maybe it has to do more with this reactivity to foods. And we found like 18 really common low glycemic foods that actually have molecular mimicry with different target proteins of islet cells that are associated with type 1 diabetes. So food sensitivities for some people can just cause low-grade inflammation. And for some other people that have this molecular mimicry mechanism, it can cause devastation. So not all foods reactivity responses are the same from one person to another. I think for most people, especially as they get older, because we lose some degree of tolerance as we age, we start to react to some foods we didn't do earlier on. We're going to see like antibodies show up in a profile. But if the antibody shows up in a profile that then has molecular mimicry with a target protein, it can be devastating and it can be life-changing, changing those foods. And for other people, they have a food sensitivity profile and they eat the food, they don't really notice much of a difference. Maybe as time goes on, they have a reaction, or maybe as different variables add into that, they start to react against the food. But I think for most people that have never had a food sensitivity test, you're gonna show up with some antibodies in certain foods. Now, we could see like a few examples of things where things are wrong. Where like if you see someone has a food sensitivity panel and they react to almost every single food, that is what we call loss of oral tolerance. So oral tolerance is not the same thing as autoimmune tolerance. Oral tolerance is reactivation to food proteins. And in the world of immunology, they use the word oral tolerance to mean dietary foods. So when people lose their oral tolerance, when we see a sensitivity panel and they have, let's say, we tested, let's say, I don't know, 250 foods or something, right? We show up, they reacted to 70% of them. We can't cut their diet out of the 70% of foods. They have nothing left to
Wow.
eat, right? And then if you just have them eat the foods that they're not reacted to and repeat the test, then let's just start reacting against those foods. So that's where you can't just remove the food. They actually have this immune tolerance issue. And then what we do in those cases is we basically leave like if there's any foods that they know directly cause reactions, we tell them to avoid those foods, but we keep their initial test as a baseline, and then we just try to improve their tolerance. Then you might ask, well, how do you improve their tolerance? Yeah. We might try to
Follow-up
have
question.
there's a lot of different diverse fibers. We may work on things like sleep, exercise, movement. We might give them supplementation for their gut. We may have to stabilize their blood sugar levels. We try to medicate their hormones under balance. We might just treat the patient as a whole to see if we can just improve all the things that impact the immune system. And then if we see like they react to 70% of the foods, and then we check them 4 months later, and now they're only reacting to 50% of their foods, then we know we're going in the right direction, right? And then maybe down the road, they're only reacting to 35% of the foods instead of 70. Then we know like we hit a home run. Probably never gonna get them to be non-reactive, like to everything. That's not realistic. But it's a progression to the right direction. And I think for a lot of people, they want to see everything be perfect, but that's not real. And you don't have to have everything be perfect on a food sensitivity panel to have dramatic results. And then there's some people that have, the classic thing is if you see all the food sensitivity, it has to be intestinal permeability. It does not have to be intestinal permeability. It could be anything that impacts immune tolerance. And sometimes it's very simple. Sometimes someone's just vitamin D deficient. You just get the vitamin D levels back up and magic happens. And other times it's just this complex web. And this is why over my years of practice, I don't know, over I think 25, something 26, maybe 27 years almost now. Um, I don't have any confidence of telling the patient this is how you're going to react. I I've
Right.
just learned to go, we don't know. Let's just see what happens. Let's just work through it. You're so unique to, yourself. You just follow with your body's signaling. Let's just keep very good track of it and see what things are responding and not responding.
It has been said that food is a potentiator for health information when your
Yeah.
body processes it in a positive, salubrious manner,
Yeah.
whereas health can also be a potentiator for inflammation. Which foods traditionally, obviously you indicated gluten. I'm assuming milk is on that list,
Yeah.
dairy. And if so,
Yeah.
why? Everybody always says to me, why? I mean, I have my pithy answers, but I want your answer.
I mean, okay, for gluten, I think it's very clear when you look at some of the protein sequences of wheat in the immunology literature, when they people who study just gluten
Mhm.
as a research field, they actually see what they call modern wheat, where the amino acid sequence of wheat has changed. So the structure of wheat has changed, amino acid sequence have changed with modernization, with haptenation, with chemicals, with hybridization of seeds. It's different. So they use the term modern wheat. And I think there's just some changes to that. I think you can say the same with many of the different reactive foods. The most common ones, like we see in practice, are for sure gluten and milk protein. There's lots of different great arguments of people that are experts in the field. They talk about milk and how we shouldn't be in animal products and things like that. I don't know. I don't have that degree of depth to go into it, but as a clinician, I can tell you milk, wheat, corn, soy, the big three with corn and soy is that they're GMO, that they've been really modified, their protein structure has changed. Those are the main ones that we see gluten, dairy, and then we also see albumin, egg protein be very reactive with many people. So, it's interesting. One of my mentors um, who really helped me in my career, and I did my PhD work in his lab, Arish Vijtani.
Right.
Uh, I go, become really good friends with him over the years, and I go, Ari, what would you do tomorrow if you had an autoimmune disease? Like, if you have a crippling autoimmune disease, what are you going to do? Because I wanted like this guy who knows everything about autoimmune disease and food reactivity, and
Yeah.
he's
Godfather.
Godfather, right? The
Yeah.
Godfather of food sensitivity testing, autoimmunity testing, functional medicine approaches to it. Like this guy, the scientist. He goes, I would go to Iran. He was from Iran. I'd live in a small village and just eat my native food. And I go, oh,
It all
okay, that completely makes sense.
says it all.
I was like, okay, so you go back to Iran, live in a farm, and have your own food there. He goes, yeah. He goes, I just couldn't risk being here in America anymore. I couldn't risk being in Europe. I'd have to go back to a small farm where we grow our own food. It's not exposed to all these different pesticides and chemicals and things that can change the structure of food proteins. So I think there's a lot of truth into how we've modernized food with different types of chemicals and pesticides and farming techniques and storage. We have so much BPA and plastics and how we store food, and we get so many things like different overgrowths of different types of chemical like yeast compounds, wheat compounds, mycotoxins in foods that we're all getting exposed to when we ingest foods today. So I think that's even part of the reason we're getting sick too. And then, when you add food dyes and chemicals to food proteins, the structure changes. It's not digestible. It's not able to be broken down. So it's more immune reactive. So I think all those things have all contributed to it. But the big players are definitely, wheat, milk, corn, egg, and soy.
So we've talked a lot about the gut microbiome. The new
Yep.
microbiome that everybody's talking about, maybe not new for you and I, is the gum microbiome. So we're
Right.
talking about gingivalis, the bacteria
Yeah.
that causes gingipans. It's a destructive enzyme, which
Yeah.
leads down a path of a high percentage of people getting Alzheimer's. Last night, they talked about gingivitis increasing dramatically the incidence of AFib. So how do you talk about the gum to gut axis?
It's really, really important. As a matter of fact, I mean, one of the screens we teach people to do when they do a new patient evaluation is to look at their gums, to make sure they don't have any indication of gingivitis. And there's all these different bacteria, Pseudomonas gingivalis being the one of the most severe destructive ones that's been linked to many things. We published a study in the Journal of Alzheimer's Disease linking it to different target proteins that involve with the beta amyloid plaques that develop in Alzheimer's disease a few years ago. And there's other pathogens as well, that oral pathogens that can do it. But like, if you like first big clue you have gingivitis is like you have really bad breath. Like, because bacteria causes, a foul odor. So bad breath and you don't know what to do about it, it's always there. That's a red flag. And as a clinician, if you're hearing a patient's history, if you're doing an exam and they just have really bad breath, you really want to look at the gums, make sure they're not tender, they're not swollen, they're not inflamed. Like overuse of mouth cleansers with alcohol really is devastating for the microbiome of the mouth. Like dental hygiene is really critical. People have to have their plaque removed, like regularly cleaned because plaque, is where these bacteria store. If they haven't had a dental cleaning in a long time, they can get this buildup of this pathogenic bacteria that can start inflaming their gums. And once that vicious cascade sets in, these bacteria can hide in different cavities in the mouth, different notches in the gum line, and it can be very, very, very hard to eliminate. So it is extremely important to have dental health. And this if this is just a reminder for people listening to go get a dental exam or get your teeth cleaned, you should do it. And especially as people get older, they're much more prone to uh, different types of gingivitis, periodontal disease. It's a big player, and part of the reason is these bacteria produce antibodies, and these antibodies can't cross-react. This is one of the studies we published. These antibodies produced against Pseudomonas gingivalis, for example, can bind to different target proteins of beta amyloid and then create that process in nerves causing this plaque development and formation. And I'm sure when they're seeing this association between AFib or different cardiovascular disease, I'm sure some of these bacteria are binding to cholinergic receptors in the heart and causing some dysfunction in those nerve plexus as well.
Yeah, I think that we just don't have enough functional dentists yet in the field to really
Yeah, we do.
grab this burgeoning topic.
I agree. And it's
Uh,
nice to see some jump in. It's
It'd be
just,
great. We're seeing a lot of pharmacists jump in. We're seeing a lot of nurse practitioners jump in. We're seeing that slow, steady stream of medical doctors. You and I both having our original doctorate in chiropractic.
yeah.
Chiropractors have been a baseline.
Right.
Because they've always thought out of the box. But I don't want to go down that rabbit hole and get myself in trouble because medical doctors taking me to dinner tonight. I want them to pay the bill. I did want to get you into some rapid fire.
Sure.
Datis Kharrazian rapid fire myths. Give me 3 to 5 myths of people who practice functional medicine.
Three misses: over supplementation, over testing, and mnemonics and generalizations for how they practice functional medicine protocols.
So you mean to say 200 pills a day is not going to solve your problem?
No, it gets to the point where you just can't utilize them, and it completely distracts people, and it really drains them. And what practitioners don't realize is when you keep making wrong steps, your patient loses trust in the model and your ability to help them.
What does the next generation of diagnostic testing and therapeutic precision look like?
I think we're going to be much more efficient at getting very accurate signaling molecules. Like, for example, if we can start measuring things like myokines, and extrakines effectively and reliably, that'll make a huge impact. If we can start to look at these peptide proteins like GLP-1 and be able to measure them accurately and see what's happening with these, it's all about messenger systems. If we can get reliable markers from messenger systems, it's going to change everything.
Your vision for the role of functional medicine in solving the chronic disease epidemic. And if not the chronic disease epidemic, how about just simply long COVID?
Well, I think long COVID is definitely linked to autoimmune being turned on by an infection. So, um, well, I think for a chronic disease epidemic, like if you have chronic disease, you many times people have chronic disease end up with what are called incurable diseases. When a person develops incurable diseases, that means no one has figured out how to cure them yet. So then your real goal in life is to try to function the best you can with what you have, so then you can have a normal life and have a highly functioning life, right? So this is where functional medicine shines for the chronic disease epidemic. Now, ultimately, preventive medicine would be ideal if we can change things that can trigger these diseases to turn on. But once the person develops chronic disease, I think functional medicine is their solution to improving the quality of life to some degree, because the goal is to try to get these systems to work better with what they have. As far as long COVID goes, we did it, I'll tell you what happened. When long COVID happened, actually, when the COVID-19 pandemic happened, like within the first 2 weeks, I get a call from Dr. Vijdani. We've done some collaborative papers, and like I said, I was able to do a lot of my PhD research in his lab. Um, and he goes, "Hey, Datis, I just got 4 blood samples from people infected in Wuhan, China with COVID, and I ran their blood work, and they have off the charts autoimmunity and
Wow.
circulating antibodies." And I'm like, "Really?" He goes, "Do you want to collaborate and write some work, do some research together?" I'm like, "Absolutely." So we first wrote a paper, we published in the Journal of Clinical Immunology, like a letter of, "Hey, we think this virus is one of the, is a virus that can really turn on autoimmunity. It's going to lead to long-term problems. We got some early blood samples. This is what we saw." It's a highly cited paper now. And we actually predicted the vaccine passport issues and all the things in this letter to the editor of the journal, which they published. And we really thought there was a really strong autoimmune component to it. So then for a year and a half, we went and got spike proteins, nuclear proteins, envelope proteins, membrane proteins of the virus, all the different branches, and then we checked over 100 tissue autoantibodies to see is there any potential cross-reactivity for these viral antibodies. In the field of immunology, there's an entire specialty where it's pathogen-induced autoimmunity. And of all pathogens, viruses are one of the strongest pathogens that can turn on autoimmune disease. And the way they can turn on autoimmune disease is when you make an antibody against, let's say, a virus protein like a spike protein or envelope protein, those antibodies can also attach to your own cell tissue proteins, which then turns on destruction against those autoimmunities. So we did this study. We checked all the different proteins for the virus, and we found this profound relationship with uh, this molecular mimicry with the SARS-CoV-2 virus and heart autoimmunity
Right.
and brain autoimmunity and some of the markers that lead to clotting. We published this in you much earlier before we started to see all these things come out, like myocarditis and neurological disease.
Right.
I think with a lot of people that have long COVID, they really have this. I'm not saying all of them, but I think there's going to be a percentage, maybe even a large percentage of patients that actually have long COVID, where they actually develop this viral-induced autoimmunity, and where they have symptoms may indicate where their pathogen, the virus, or even vaccine-induced autoimmunity. That's another field of study in the field of immunology. Um, where they're having symptoms. So if they, for example, got exposed to the pathogen, or let's say a vaccine, and all of a sudden they have complete neurological deficit and can't think and can't focus and have weakness and balance issues, they might want to go and check like the myelin basic protein, neurofilament antibodies, like neurological autoantibodies, see if that's an issue. If someone, started to develop different types of, let's develop type 1 diabetes, go and check islet cell antibodies. Well, there's a strong relationship between people that develop Hashimoto's and getting the infection. We found strong relation between TPO and thyroglobulin cross-reactivity with SARS-CoV-2. So I think a lot of these people who have long COVID may not really realize that their virus may have turned on an autoimmune disease specific to target proteins. Most likely in the list that we published, we were the first people who published that.
Read that article.
And many different autoimmune diseases can be triggered by this specific virus.
I never revealed this. I mean, I read the article that there's no hidden agenda there, but I was very concerned about how the immune system was being depicted by the TB doctors. And then I read your guy's article,
Yeah.
and that spurred me on to write my book, Immune Reboot. I just hadn't
Oh,
told anybody that. I was waiting to get you on,
oh,
a
cool.
little feather in your cap. So thank you
Oh,
very much. I appreciate that. Interesting. I've done a lot of blood work also, and that virus, that COVID virus, is gnarly. It woke up all these antibodies. So maybe you can explain to everybody why I've said that getting COVID increases the antibodies in Epstein-Barr, Lyme,
yeah.
pneumonia, etc.
Yeah, there's this phenomenon with pathogens, it's called polyreactivity. You start to make antibodies at a much higher rate for some of the viruses. Like if you check the population for Epstein-Barr, I mean, I'm not sure what the numbers is, but it's like 98% of people will have some Epstein-Barr antibodies from past exposures, maybe from past infections. But a lot of times when you get a pathogen in, they can cause this polyreactivity reaction where you get multiple antibodies elevated. Those antibodies will have an effect on tissue. They'll have some adverse effects on tissue. And sometimes it's like when we do a panel, like we'll do like a pathogen panel with like 24 different pathogens, all of them will be off the charts. That's called polyreactivity. So this polyreactivity can be triggered by certain infections, and this polyreactivity can also be triggered by cancers. So like if we do like I'll run a panel where it checks 24 pathogens at once, and if I see everything off the chart, I know they have polyreactivity, and like we have to go, is there cancer in this patient?
Wow.
Or is there like this active infection that's there? So that's a phenomenon in immunology. It's very interesting, where the whole immune system just revs up when it's under attack especially by specific pathogens. SARS-CoV-2 can definitely cause polyreactivity in some people.
I'll tell you, those antibodies have been raised. I got two more for you. The biggest bottleneck in getting patients real answers, because I know that is something that you're most concerned about. Is it biological, educational, or is it systemic? One of the biggest complaints I get from patients is that they don't really understand what the doctor said.
Yeah.
They lost confidence in the medical field, unfortunately.
Yeah.
So that idea of they're all bottlenecked and kind of funneled into one thing, as opposed to really looking at the whole field. Sometimes a doctor becomes myopic And you're
Yeah,
talking about looking like the whole field. You said you didn't like a lot of sports. I love quarterbacks and point guards because they have to look at the whole field to be
right.
effective. Same thing with the doctor.
That's a hard question. I have the same frustration they do, you know. Like every time I had a family member when I had my daughter was born, I was just to go to pediatricians took me a hard time to find the right pediatrician. I didn't trust anyone.
Mhm.
I didn't do anything. I have this antitrust against everyone in healthcare, including my own bias when I read information and say things. It's a big problem because it's so complicated and so difficult. I think the biggest bottom, I think there's a few issues. First of all, if you have chronic disease, you cannot be a passive patient. If you're a passive patient just wanting to hand something over to a practitioner, you're guaranteed to have a case fail. Like if you have a chronic disease, you have to all of a sudden become an expert. You have to dedicate some part of your time and life to really understanding the condition and the disease, which many patients do. I mean, there's the all-star patients that come in, they like know all about their case, and then they're teaching like you as a practitioner about something like, I didn't know that. Thank you for teaching me. Give you
Yeah,
all this
agreed.
papers and information. You're like, okay, you're awesome. And you look forward to seeing them each time because you know they're going to teach you something. And then at the same time, you go on a journey together. I think the key thing is when you're dealing with a chronic disease, first of all, that the patient themselves cannot be passive. They have to be an active participant. And you should expect to have everything fail with you if you become an active participant. And even I can tell you, even some of the top best practitioners in the world I would go see, they're overwhelmed. They don't always, they do the best they can too, but the cases are complicated. So being active can keep them on track too. Sometimes they deviate. So the more you know about the case, the better. And also, um, there's got to be this trial and error. There's this discussion of like working through things and figuring things out. Like there's no simple, I've got the answers for you. I think the key thing is don't get focused on having the answers, understand trial and error, work with someone who's got trial and error. And that involves like communication, the practitioner, education and knowledge in that field, but also patients not being passive and really trying to understand whatever they can about it.
Let's close with what's next for you. I mean, you've clearly done so much in your 26-year illustrious career. Yet, what's most compelling is, talking to you before we came on, you're still at it, man. You're still thriving. You're probably more energetic and more driven than you were 10 years ago. What's next?
Yeah, and I would tell you, like, I just feel like, man, I'm getting older. I only have so much time left, and I'm just learning, and I just want to do stuff now. I'm sure you feel the same way. It's like everything you've built up to your knowledge base now is just starting to make you feel a little more comfortable, and then you're like, I just need another 30, 40 more years.
Well, you've got that in the bag because, you're all about health and functional medicine and all that. One thing is my friend always listens, Oxford grad in Geneva, and he always says, listen, keep it simple for me. Give me one thing at the end of the podcast that if I had to listen, that I could do tomorrow to make my life better.
So I think, listen, for me, where I'm at in my journey right now is my role is really an educator. So I've had the most profound impact teaching other physicians and practitioners healthcare. So the Kharrazian Institute has become a central part of my my life mission to just create educational programs that teach practitioners because when they learn, they have an impact on their populations, which is much more profound than me working with a patient one at a time. And the two education sources I have right now are focusing all my time in right now is the Kharrazian Institute and the Academy of Functional Nutrition and Lifestyle Medicine, which is more of a nutrition program. And we open that program up for also general public and practitioners because you know that a lot of the general public that are passive patients need to understand basics of functional nutrition, diet, and lifestyle for themselves instead of being what to do. So the program's open for practitioners and the general public to go through. So right now I'm just trying to really uh, understand how they're responding to the education. What are some of the deficiencies in it? How do we optimize it? How do we make it better? And that's really been my passion project.
Well, keep going. Love it.
Thank you.
Love all that I learned from you. Thank you very much. That's the number one thing that everybody told me to say to you. Thanks so much for setting such a high bar and a standard. It's not a problem. I love grabbing low-hanging fruit and climbing up the tree. I'll see you at the top. Everybody, Dr. Datis Kharrazian, Rob Silverman, Proven Health Alternatives.